But all of you kindly pay attention. This lecture will be divided into two parts. The first one will be a relatively theoretical discussion of around 25 minutes or so. And thereafter, I'll go to a repertoire of cases which I have been collating from 2008 onwards. And those X-rays I will show you, and all those will covering the different focal lesions in MSK X-rays. So without any wasting any time, let's start. I bring you greetings from two great institutions which have shaped my career. The ultimate approach to focal bone lesions involves a lot of meticulous work because we have to provide a reliable and reasonable differential diagnosis. Using plain films, we have to tell the biological activity of the lesion as well as probable histological diagnosis, which though appears as a daunting task, but is relatively simple if you break it into uh, proper algorithm and steps. Patients usually present to us either in form of pain, palpable lump, a pathological fracture, or sometimes the X-rays that we get of focal bone lesions are plain and simple incidental findings. Whenever we get focal lesions in a bone, we are at a loss of words and loss of thoughts. Now, something looking as simple as this lesion or looking very difficult and aggressive as this lesion, how to differentiate, how to put them together in correct perspective, and how to give a differential diagnosis for each one of them. That is what we need to learn today. Our aim is to detect where there is a lesion, then what is the lesion or lesion characterization, stage the lesion with local and distant metastasis if present, how to guide the biopsy to the most active site of the lesion, and whether biopsy is required. Of course, follow-up of the lesion is also important. If you are saying that, telling the patient that this is totally a benign thing and you need not do anything about it. So there are four clinical situations when it is a normal finding but the patient has symptom. Second situation when there can be abnormal findings on radiograph and there is suspected METS or multiple myeloma. Radiograph may be abnormal with a non-aggressive tumor and radiograph may be abnormal with an aggressive appearing primary bone tumor. Now let's always stick to algorithms whenever you are met with a skeletal X-ray. To start with, the first thing to note is the age and sex of the patient. It is always told that there are four corners in an X-ray film, and those four corners are absolutely important because they share demographic data about the patient. Whether the lesion is single or multiple, where is the location of the lesion? Which bone is it located in the skeleton? Then in the particular bone, which part of bone is involved, whether epiphysis, metaphysis, diaphysis, central or eccentric lesion. And thereafter, the important factors related with the lesion itself, which tell us or give us an indication that whether the lesion is a benign one or a malignant one. These five characteristics include border, presence of bone destruction, periosteal reaction, the matrix of the lesion, and whether there is a soft tissue mass associated with it. We will see this in details. The modalities at hand with us include plain radiographs, ultrasound, CT, MR, angiography for few lesions, and of course, nuclear medicine. But plain radiographs are the traditional way and they still hold relevance. Never attempt to see an MSK, CT, or MR without a plain radiograph. The appearances will be blaring and it will always hold you in good stead if you have an MSK X-ray to start with. Now, differentiation of lesions between benign or malignant, as I told you, is a 5-step process. So, first thing you have to see is whether there is cortical destruction present or absent. The rate of progression, whether the lesion is a slow growing lesion or it has rapidly progressed to a large size. Whether there is large soft tissue component associated with it or not. Periosteal reaction, whether it's an uninterrupted type or interrupted type. And if the lesion has a wide zone of transition or a narrow zone of transition. Important thing to note is large lesions size more than 5 centimeters are always suspicious for being neoplastic in etiology. Now, when you get a plain radiograph, you have two important characteristics, whether the lesion may be lytic or sclerotic. What does lytic mean? That means the density of the lesion is less than the normal bone. And sclerotic means that the density of the lesion is more than the normal bone. In lytic lesions, they may be well defined or ill defined. If it is an ill-defined lytic lesion, go and look at the age of the patient, whether it is young patient or relatively older age group, wherein the diagnosis of neoplastic etiology would be higher on the cards. See the location of the lesion in cross section as well as side section. That means in cross section, you will see whether the lesion is located in the central part, whether it is medullary or cortical in location. And in longitudinally, you have to see whether the lesion is epiphyseal, metaphyseal, or diaphyseal in location. Then the location in which part of the bone in the skeleton is involved, whether it is long bone or the spine which is involved. Miscellaneous points include assessing the periosteal reaction, cortical destruction, and then comes whether the lesion is solitary or multiple. So, few examples of sclerotic or lytic lesions. If the patient is less than 30 years of age, then it is a sclerotic lesion, then in the metaphyseal region you may get enchondromas. What happens with increased density in the diaphyseal or metadiaphyseal region? It may be non-ossifying fibroma or fibrous cortical defect. Osteoid osteoma is also a cortical lesion which is sclerotic and seen in people who are less than 30 years of age. However, if the patient is more than 30 years of age, metastasis, parosteal osteosarcomas, high-grade chondrosarcomas, these are much higher on the list. Coming to lytic lesions, young patients think about osteosarcoma if it is a metaphyseal location and osteomyelitis also. Whereas in diaphysis, lytic lesions think about Ewing's or eosinophilic granuloma or leukemias. Whereas in older patients, three important diagnoses you should always keep in mind, that is METS, myeloma, and lymphoma for lytic lesions. Now, in patients more than 30 years of age, a GCT can be located in a subchondral location. So, epiphyseal location is very characteristic for a giant cell tumor. Age of the patient, how does it affect our differential diagnosis list? In patients who are less than 30 years of age, Ewing's, SBC, ABC, these benign etiologies definitely are higher on the cards. Whereas as the patient gets older, I told you MML, metastasis, myeloma, and lymphoma definitely gets higher on the card in differential diagnosis. In less than 1 year of the age, that means infants, metastatic neuroblastoma is a very important differential diagnosis to be considered if you have a lytic lesion. In 2 to 30 years, osteosarcoma and Ewing's must be considered. And as you go higher in age group, MML takes priority. GCT has to be set only after skeletal maturity. If the patient is young and the epiphysis has not yet fused, then aneurysmal bone cyst is the possibility. Simple bone cyst before skeletal maturity is more common in proximal humerus and femur. And after skeletal maturity, calcaneum scapula pelvis, that means all membranous bones can have SBC if there is a lytic lesion. Now, bone which is affected, whether it is spine or long bone, that is very important when we go into list of differential diagnosis. So within the bone, see for the epicenter of the lesion, whether it is central, eccentric, cortical, or parosteal, and which part of the bone long axis the lesion lies, epi, meta, or diaphysis. Because very few lesions have very specific site, like in tibia, advantinomas are seen in the diaphysis and NOFs in the metadiaphyseal junction. So these diagrams are very easily available. However, how to differentiate them? how to say that they are benign or malignant. We will learn each one of them. Now see examples of simple bone cyst, well-defined lytic lesion, which is expanding the bone in the diaphyseal region, and it has a narrow zone of transition. You can see very well the difference between a normal bone and where the lesion starts. There is no ambiguity about it. There's no cortical destruction, no soft tissue mass associated, no periosteal reaction, much more inclining towards a benign etiology. Again, important example of a lytic lesion located in the cortical area of a metadiaphyseal junction in a tibia. Very common site for a non-ossifying fibroma or fibrous cortical defect. Third example of a simple bone cyst. See that the skeleton is immature and the lesion is expanding the bone. Fibula and humerus are very common sites of simple bone cysts in such age group. Cortical lesion, which is causing sclerosis and has a central lytic nidus, and that is an typical appearance of an osteoid osteoma. Fifth example, a subchondral cyst in a degenerative knee. Sixth, aneurysmal bone cyst. Few septations are present as we can see that in the lesion there are few septations also present and the bone is expanded. So in such cases, the differential diagnosis would include SBC, ABC. However, this could turn out to be any of them as the histology would suggest. But these are touch me not lesions and should not be touched unless associated with a pathological fracture. Predilection of lesion for specific bone. Osteofibrous dysplasia. These are dysplasias which are commonly seen in immature skeleton in children, and adamantinoma. These two lesions have a tibial predilection. For specific site in a bone, then chondroblastoma has a very high specificity for occurring in the epiphysis of a long bone. It appears like a lucent lesion with sclerotic border in the proximal epiphysis of tibia, and lucent lesion with chondroid kind of calcification. That means ring and arc like of calcifications. You must think of chondroblastoma. If these calcifications are not there, the lesion is more lytic. Think of GCT. Predilection of specific site in a bone. Very important example is parosteal osteosarcoma, which has a very high predilection for posterior aspect of lower end of femur. Similarly, as I told you, GCT has the predilection for epiphyseal region of long bones. In that, humerus proximal aspect, femur distal aspect, and tibia distal aspect, and even radius distal radius is a very common site of GCT. Central location within the bone is specific for SBC, fibrous dysplasia, and enchondromas. Now, how do you differentiate simple bone cyst, lytic lesion with with no periosteal reaction, cortical destruction? Few septations are not visible here, so ABC is low on the cards. FD with ground glass appearance of the matrix, fibrous dysplasia. FD is fibrous dysplasia. Enchondromas, centrally occurring lesion with rings and arc type of calcification in a long bone is very highly diagnosis of enchondroma. Differentials in this case would be medullary infarcts, eccentric location of tumors, eccentric location of lesions. ABC is more eccentrically located as compared to SBC, and that's where the differentiation between them lies. Also, you can see thin septations within the lesion as is commonly seen in ABC. Non-ossifying fibromas, these are increased cortical, seen as lytic lesions in the cortex in the metadiaphyseal region. CMF, chondromyxoid fibroma. These are mixed lytic sclerotic lesion. However, they expand the bone, but there is no periosteal reaction and no cortical destruction, usually eccentrically located. Other features we have discussed till now. Tissue of origin, how to differentiate osteoid or chondroid matrix. Margins of the lesion, the pattern of bone destruction, the zone of transition, periosteal reaction, and soft tissue extension. This is what we need to know. So let's see about lesion matrix. Whenever there is osteoid matrix, we will see fluffy and trabecular new bone formation, which will be more sclerotic or more density rather than the normal bone. So these fluffy kind of opacities, cloud-like opacities, cotton wool, trabecular disarray, all this will be seen in osteoid matrix. In chondroid matrix, there will be rings and arc type of calcification, which will be amorphous or stippled. It will not be dense or cloudy or fluffy. So this is how you will differentiate between osteoid and chondroid matrix. Now, bone producing or cartilage producing tumors, this if we can identify, our list of differential diagnosis definitely narrows down. The bone forming and cartilage forming tumors are aggressive tumors, and they produce amorphous osteoid, less dense than the normal bone. However, they will be fluffy and trabecular disarray will be there. Less aggressive tumors form better organized and denser bone. The cartilage producing tumors produce rings and arc type of calcification. So this is what is meant by osteoid matrix, in which there is trabecular formation. They may be less dense than the normal bone, but there will be trabecular disarray. Chondroid matrix will show rings and arcs type of calcification. So this is an example of osteosarcoma, and this is an example of osteoid osteoma in a digit. Here, the tumor that is shown is a chondroid matrix of osteochondrosarcoma. Now, lytic bone lesions are classified by Lodwig's classification also, in which if there is a complete margin outside the lesion and it is a thick margin, sclerotic margin, it is called 1A. If it is an interrupted thick sclerotic margin, it is 1B. If the margin is interrupted in one side and the lesion is not completely surrounded by a dense margin, it is called 1C. A margin which is irregular, ill-defined, and eccentrically located lesion is classified as 2, whereas a permeative lesion or moth-eaten appearance is given as class 3 according to Ludwig's classification. Margins of a lytic lesion. Now, if the margins are well defined, then the lesion is likely to be less aggressive and in the benign category. So 1A category with well-defined sclerotic border, very common of an enchondroma. Type 1B, bony lesion with non-sclerotic margin. But would you have this in a epiphyseal location, GCT or chondroblastoma? Those are the most important two differentials. There can be bone lesions with usually a sclerotic border and those who lack a sclerotic border. So the list is given everywhere in the books. However, today we are here to discuss about the real cases. So I'll go on, and this you can read from the book. 1C is geographic margin with ill-defined border. Permeative destruction is commonly seen in Ewing's, in which there will be onion peel type of periosteal reaction and decreased density of the bone. In multiple myeloma, there will be moth-eaten type of destruction. There will be areas which will be lytic, then there will be few areas which will be sclerotic. So this is, and as you can see, you cannot differentiate where the normal bone ends and where the affected bone starts. That is the differentiation, or that is the definition of wide zone of transition. That means you are not able to differentiate where the normal bone is ending and where the lesion is starting. Pattern of bone destruction. Bone destruction pattern we can define it as very well defined margins surrounded by thick sclerotic margin as in CMF. In osteosarcoma, interrupted margin, there is cortical destruction. In Ewing's, the margins are ill defined and there is permeative kind of bone lesion appearance. Now, ballooning is a characteristic feature seen in GCT. There is a lytic lesion at the epiphysis, at the metaphysis, And the lesion appears to be expanding the bone and causing ballooning of the bone. That means there are large areas of expansion along with septate formation, and this is very characteristic of a GCT. Endosteal scalloping. This means that there is destruction of cortex outside or endosteal scalloping. Sharply marginated destruction of inner margin of cortical bone is seen. This endosteal scalloping is a feature which is associated with enchondromas, sometimes seen in multiple myelomas, especially plasmacytomas, and low-grade chondrosarcomas. NOF adenoadenoma are also sometimes associated with endosteal scalloping. However, characteristically, plasmacytoma and enchondroma are the two lesions which are associated with endosteal scalloping. So, trabecular destruction, this is very important. If you see in normal X-ray, sometimes when you get it for daily reporting, trabecular destruction may not be really apparent, and it takes a careful eye to pick this up. However, can you, if this X-ray is just put to tell you that sometimes the lesion may not be very visible, but you have to be really careful and compare with the other side, because this patient actually had an events which involved trabecular destruction, and so much of lesion was apparent on MR. Now, next we come to zone of transition. As I discussed before also, that narrow zone of transition means that we have a clear distinction between where the normal bone ends and where the lesion starts. Like here, in this GCT, you can see that there is a clear and very narrow zone of transition between normal bone and the lesion. However, in this case, there is an aggressive lesion that is involving the fibula, and there is cord reaction. There is a large lytic lesion involving the diaphysis of the fibula, and there is wide zone of transition. It is very difficult to differentiate from where the normal bone ends and where the lesion starts. There is large soft tissue effect that is seen, soft tissue mass associated with the lesion. You can see the elevation of soft tissue planes, and there is thick periosteal reaction, interrupted type. And in the proximal part of the lesion, you can see that this is a Codman triangle type of periosteal reaction. Narrow zone of transition is typical of benign lesions like non-ossifying fibromas, SBCs, or ABC. Wide zone of transition is very characteristic of malignant lesions and infective lesions, because there is infective and malignant lesions are difficult to differentiate on radiograph alone, and even without after doing MR or so, sometimes there is a difficulty to differentiate between infective and malignant lesions. Eosinophilic granuloma is one of the benign lesions which shows a wide zone of transition and difficult to differentiate on X-ray alone. Next, we come to periosteal reaction, another feature that helps us differentiate between benign and malignant. If the periosteal reaction is solid or uninterrupted, then it indicates a slow growing lesion and likely to be a benign etiology. But as we go along the right side of this image, we can see that lamellated, spiculated, and Codman's angle progressively indicate that the lesion is becoming aggressive and more aggressive. So solid periosteal reaction is, if it is a single lamella, it is very indicative of stress fracture or LCH. Undulating solid periosteal reaction can be seen in varicosities or chronic lymphedema. Solid type reactions are also seen in ABC and osteoid osteoma. But interrupted periosteal reaction in benign conditions, then you have to think of osteomyelitis, LCH, and subperiosteal hemorrhage. Few examples of solid periosteal reaction seen in osteoid osteoma, hypertrophic pulmonary osteoarthropathy, osteoid osteoma again, a CT image showing a lytic nidus within, LSH showing a thick periosteal reaction, and ABC showing a solid buttressing kind of periosteal reaction. Interrupted periosteal reaction can be three types: sunburst, Codman's triangle, or onion bead. Sunburst is characteristic of osteosarcomas. Codman triangle is also commonly seen in osteochondromas and chondrosarcomas. And onion peel is characteristic of Ewing's. How is the onion peel appearance? As if you've seen while cutting onions, you see multiple layers of the onion. It's just like that. Multiple peels or multiple layers are associated with this kind of interrupted periosteal reaction. Now, soft tissue extension or primary soft tissue tumor. Many a times the primary bone tumors have a large soft tissue component. So there's a doubt in the mind of the radiologist whether this is a primarily a soft tissue lesion or primarily a bone lesion. So to differentiate or to answer this question, you have to see epicenter of the lesion, the beveling of bone, periosteal reaction and size of the lesion. And there is a small diagram which helps you to differentiate between soft tissue and bony lesion. If it is a primary soft tissue tumor, then most of the lesion or epicenter of the lesion will be outside the cortex. But if it is a bone tumor, the epicenter will be inside the bone. The soft tissue tumor will bevel the cortex towards the bone, whereas the bony tumor will bevel the cortex outside or towards the soft tissue. The periosteal reaction will be absent in case of a primary soft tissue tumor, and there will be a lot of periosteal reaction in association with a primary malignant bone tumor. The size of the lesion, the large soft tissue lesion may indicate a large soft tissue mass. However, in bone tumors, sometimes soft tissue mass will be small. However, sometimes there may be large soft tissue component also. So with this, we have finished the other features. We have finished the age of the patient, sex of the patient. We have finished other features which we have to identify to narrow down our list of differential diagnosis, which is the tissue of origin, the margin of the lesion, pattern of bone destruction, zone of transition, periosteal reaction, and soft tissue extension. So whenever you're describing a lesion, these features should automatically come out of your mouth while describing the lesion during viva, and that will complete your description of the lesion. And if you have described the lesion well, gradually you will develop an algorithm and you will automatically reach your differential diagnosis. So these are few figure examples to help you revise the common location of the lesions. Next, we come to lesions which are multiple by nature, like malignant lesions like multiple myeloma, METs, and lymphoma, and benign lesions like polyostotic fibrous dysplasia, enchondromatosis, and multiple syndromes that are associated with that, LCH, and cartilaginous exostosis or diaphyseal eclasias. Next, we come to touch me not lesions. If you see such lesions, you must tell the patient as well as the orthopedician that nothing has to be done about it. I have seen, so I have to tell that it is present so that next time a radiologist sees it, he or she knows that it is a touch me not lesion present and it is not a new finding on a radiograph or a MR. So if this is a list of touch me not lesions, I would request all of you to go through this. Many of this we will see in the cases. So I have given you enough and more indications of how to assess between benign or malignant. C for cortical destruction, rate of progression, soft tissue component, periosteal reaction, and zone of transition. And you will have a clear and fair idea whether the lesion you are dealing with is benign or malignant. So sharply defined lesion with sclerotic margins or geographic type of bone destruction, narrow zone of transition and uninterrupted periosteal reaction with almost no soft tissue component is a benign lesion, whereas poorly defined lesion with moth-eaten or permeative destruction, interrupted periosteal reaction and large soft tissue component is likely to be a malignant etiology. Some lesions can be there which are benign, which have aggressive features, especially infective lesions like osteomyelitis, and large bone expanding lesions like GCT and ABC, osteoblastomas. They can have aggressive features. However, when you see for follow-up, they'll be so slow growing. Benign conditions which have potential for malignant transformation are shown here. And if there are syndromic associations with these lesions, then they are more likely for malignant transformation. What is the role of ultrasound now? Should you do ultrasound always? No. Adjunctive role of ultrasound is there. Main thing is your plain radiographs. And ultrasound, however, can help you during FN or biopsy, detecting sarcoma recurrence, monitoring response to therapy by comparing the Doppler indices in the limb arteries. Well, how does CT help us? CT can also help us to grade lesions like grade 1 indolent lesion, grade 2 aggressive lesion, and grade 3 highly aggressive or permeative lesions. Other applications of CT include to assess the extent of tumor and if it lies in a complex structure like pelvis or sacrum or scapula, then it tells you about the complete extent of the tumor, epicenter of the lesion, whether it is in soft tissue or bone, surface lesion that occur in bone like juxtaortical chondrosarcoma, parosteal osteosarcoma. CT is very helpful for those lesions. 3D images can be made and matrix can be properly identified. And also in patients in which MR is contraindicated and you need a cross-sectional modality, CT would help. MR, of course, is the very important investigation for accurate characterization of the lesion, the soft tissue extension, bone marrow edema, accurate staging with joint and neuromuscular involvement. Skip lesions can be assessed in cases of neuroblastomas and osteosarcomas. Therapy planning and monitoring after treatment. Post contrast study helps us to differentiate between edema and tumor tissue. Diffusion helps us to assess response to chemotherapy, and MR spectroscopy helps to determine the characterization of tumors. Angio is helpful for differentiating benign and malignant if there is encasement of normal vessels or presence of tumor vessels. Mapping the vessels to plan salvage procedures. Sometimes you need pre-op embolization to reduce hemorrhage during surgery. And also these days we have angiography for delivering intraarterial infusion chemo. Nuclear medicine technetium 99 scan helps us to see newborn formation activity. Whether the lesion is monoostotic or polyostotic, that information we can get. However, it has low specificity. FDG PET is always obviously it takes uptake by tumor cells. It guides biopsy to the correct site, and it can help to differentiate between recurrence and post-therapy changes and monitor response to therapy. Now, this is the Enneking staging system for primary malignant tumors of the bone. This was given in 1980. What we use now is the AJCC staging system for malignant tumors of the bone. If you see a lesion and if it is likely to be malignant, then you have to tell about the staging, of course. So, few examples, 3-4 examples, and then we go to the cases discussion. 24-year-old woman with telangiectatic osteosarcoma, plain radiograph shows a poorly defined lucent lesion in the proximal tibia. So if you are not careful with your x-rays, this may go as a pass also. But you see that the lesion, the bone in this area is not normal. It is showing moth-eaten type of destruction. And on the MR, of course, the lesion is very apparent and easily seen. There is hemorrhagic tumor in proximal tibia. However, soft tissue component is very small. Now, this is a characteristic spotter, which is many a times put in spotter section, and it is parosteal osteosarcoma. Characteristic location, how do you identify? There is a cleft between the normal bone and the tumor. And that is why you say that it is a parosteal osteosarcoma. Most of the component of the tumor is lies in the parosteum, and the normal bone is not infiltrated. Onion peel type of reaction, characteristic appearance of Ewing's lesion, moth-eaten permeative kind of destructive lesion with onion peel periosteal reaction, large soft tissue component. It in a diaphyseal location in an immature skeleton, you have to give Ewing's as your first differential diagnosis. Now, this is also a young patient with immature skeleton, 17-year-old boy with large destructive lesion in the proximal humerus with some cortical destruction seen in medial as well as lateral aspect of the humerus. As far as you can see, the bone is involved and there is a huge soft tissue component associated with it. There is a trabecular disc array and cloud-like or fluffy calcification or ossification, new bone formation that is seen inside the soft tissues as well. And here in the distal part of the bone, you can also see Codman type of periosteal reaction. Large soft tissue component and new bone formation, osteosarcoma. And CT of the patient, CT chest showed large cannonball metastasis, multiple nodules, random size, randomly distributed with pulmonary metastasis. Now, this example of another aggressive lesion in the diaphysis in the of the radius, and you can see what is happening. There is a periosteal reaction, cortical destruction, moth-eaten type of appearance of the bone, and large soft tissue component. This type of periosteal reaction is both Codman strangle as well as sunburst kind of appearance. And on the bone scan, the primary lesion is also seen, and is also there is another area of uptake in the left knee as well. So there was a deposit in the left knee also. So metastatic neuroblastoma is on the cards. Next, we come to report template. This is one slide which is very, very, very important. Whenever you are reporting a musculoskeletal X-ray, you must include these points. This will ensure that the answer you give in Vivas is complete, and you will reach your differential in an algorithmic manner. So whenever you describe a lesion, see the radiographic quality. There should be two views available, whether it is lytic or sclerotic, and age of the patient, location within the bone and longitudinally as well as in transversely, size of the lesion, matrix of the lesion, zone of transition, cortex, periosteal reaction, soft tissue component, and whether other such lesions are present in the visualized radiograph or not. To summarize, prepare well. Opportunity meets preparation, and that is success. Plain radiograph is your bread and butter. You cannot not know them well. Describe a bony lesion well, differentiate between benign and malignant, and give a possible differential diagnosis. These are my acknowledgements, and with a small break, I would like to share my next presentation. So as I promised, initial part was a little bit theory. However, now we go to actual cases. These cases I have curated from 2008 onwards. So you will be able to, I hope you are able to benefit from these cases, because these are a large repertoire of cases, and I would like to thank my seniors for making me it a habit in me to always keep curating cases, not knowing when they will be useful. But I think curating and keeping cataloging cases is very important, because sometime or the other, your students and next generation will definitely benefit. So let's start with focal bone lesion cases. At this time, I will activate the chat box. So if you are able to see my chat box, can any one of you, two, three of you, just type yes in the chat box? If you are able to see. Okay, great. So just one or two responses, if I keep getting, I'll be able to understand that everything you are understanding, and we will discuss these cases. So it is 7:41. I still have 20 minutes and I have around 38 to 40 cases. So we'll go quickly, but of course, it not at the expense of you all understanding. It is very important for you to understand and be able to pick up things. Right. So, okay, this is the first case, case number 1. Whatever you see and whatever you feel is the diagnosis, you can type in the chat box. Yeah. Chondroblastoma, GCT patella. Okay, I got a few. I'll move the chat box on the side a little. Right. Good, good. Very good. So 4, 5 people, if they keep answering, it will keep me going. Yes. So first important good thing is that you have picked up that the lesion is in the patella. So one battle, one step is done. Then there is a benign lesion. So somebody said benign lesion, and that made me really happy because see how the margins are. They are well defined, cortical, and there is no bony destruction. There is no periosteal reaction, soft tissue component. So definitely, one thing you have picked up a lesion. Second thing, you have understood that this is a benign lesion. So half the battle is won. So this was indeed an enchondroma of the patella, and this was the appearance of CT appearance, well-defined lytic lesion. So this was a benign lesion of the patella. Let's go to case 2. What do you think of this radiograph? Okay, where is the lesion? What you can do, all of you, when you are answering in the chat box, you can write two and then answer so that I can understand that we are talking about the case number 2. Okay, great. So you write 2 and then you write your answer. Correct, correct. Very good. So this is very rightly answered, osteochondroma of the neck of femur, and this is a benign lesion and touch me not lesion. But what do you think the patient presented as? The patient presented as pain. And why is the pain happening? Because now the osteochondroma is growing. So the cartilage cap on this started growing and it started irritating the neurovascular structures. And that's why the patient started having pain. And then this radiograph was done. Till now, he did not have any problem with this lesion. However, the just by the size of the lesion and growth of the lesion, it is now causing a symptom, and that's why the radiograph was done. Right. So we go to 3. What do you think? Where is the lesion? Is there a lesion? Where is the lesion? Third one. Very good. Malignant transformation, more than 15 millimeter cartilage cap. Shruti, for osteochondroma. That was case 2. So I'll request all of you to just write 3 and then write, yeah, 3. Okay, go on. I have got diaphyseal lesion, myositis ossificans. Okay, I can see that people are writing soft tissue lesion. So that is one thing that is giving me happiness because what you can see is the bone or the humerus that is shown here in 2 views is relatively normal. The lesion that is there is in the soft tissues or in the medial aspect of the arm, and it has large calcification or macroscopic calcifications within. Few of these calcification have a central lucency. So typical of phlebolith. Absolutely. Dr. Zainab has absolutely nailed it. And these are phleboliths. So this is an AVM of the in the arm. And the bone is absolutely normal. So differentiation between soft tissue lesion and bony lesion. I hope that this case brings you a little clarity. Slow flow malformation, yes, it can happen. It can be a hemangioma, it can be an AVM, it can be anything. But thing is that it is a soft tissue lesion with phleboliths within. Next case. I have already given you few hints, so I'll not ask you to type it out. But this is of course a pelvis X-ray with both of the head of femur showing features of avascular necrosis. There is sclerosis. There is collapse more prominent on the left side, and there is uh, lot of degenerative changes. Now, the same thing was seen on CT, and on CT was also seen was the crescent sign or the snow cap sign, which was more prominent on the left side. See the type of collapse that is happening and the destruction of bone that is happening in the femoral head. So for avian, this is a much more milder case. I will tell you that this is also avian. I'll remove the chat box also so that you can see the other one. So here you can typically see the subchondral cyst, a little bit of osteopenia, and there is also widening of the neck of femur because there will be stress on the neck as compared to the head. The head is not able to take the load which is it is supposed to do, and that is why the neck widens in cases of avian also. Fichet-Arlet is the staging system that you must mention in your diagnosis if you are given a radiograph or a MRI of avian. Next, case number 6. 6, again a pelvis radiograph. So what do you think is the lesion? 6 is bone island. Dr. Harsh has given the correct answer in the first instance itself. So yes, there is a bone island in the left femur in the interchondral region, intertrochanteric region, and that's why it is so evident why it is benign, because there is well-defined lesion, there is no cortical destruction, no periosteal reaction, and it is a touch me not lesion. You just have to tell the patient that it is there. That's why I'm telling you. You need not do anything about it. Someone is asking, Dr. KP is, Shruti is asking me, why not enchondroma? Enchondromas are lytic lesions. They are chondroid matrix. Okay. So chondroid matrix will always have ring and arc type of calcification. I have enchondromas, example in the cases. So just hold on, just go on with me and you will understand why it is not enchondroma. Okay. Typical appearance of enchondroma I'll show you. Now see case 7. What do you think it is? Great. Dr. Ganesh has nailed it. Uh, there is a large expansile lesion in the epiphyseal region of a mature skeleton. Okay? Just look at the bones. They are fused. Epiphysis, metaphysis is fused. So now you will not think of chondroblastoma. Okay? So epiphyseal lesion in a mature skeleton with ballooning of the bone. There are thin septations within, no cortical destruction, no periosteal reaction, and it is a GCT. Okay, case number 8. There is a skull X-ray, lateral view, and there is a pelvis. 8 number. Case number 8. Okay, one person has given me a differential as multiple myeloma. Next, I get Paget's as a differential. One more thing that you have to think about in this kind of appearance. 2 differentials you have given me correct. Metastasis is, somebody gave me metastasis. Okay. So multiple myeloma, then Paget's and metastasis. So this is a patient, it is around 65-year-old patient with CA prostate, and these are large sclerotic ill-defined metastatic lesion in the skull also and in the pelvis, also in the spine. This is how his rest of the spine looked like, lytic lesions and mixed lytic and sclerotic lesions all over. I'll move the chat box so you can see. This is how his spine was looking, and there was compression fracture also seen in few of the vertebrae. Right. So case 8 was metastasis, mixed sclerotic lytic mets of CA prostate. Now case 9, I have already written the diagnosis. So you just have to see how will you describe this lesion. Now this is not a typical focal benign or malignant bone lesion, but I have kept you because this is an MSK class and exam is on the cards. Exactly. Iced candy-legged appearance of a Charcot joint. So what do you see? There's increased density or sclerosis because of a long-standing process. There is destruction of the joint. There is dislocation of multiple joints. There are loose bodies present within the joint, which is called debris. And there is destruction of joints and distension because of effusion present within. There is bone loss. And this bone loss gives the appearance of iced licked candy stick appearance, and which is very characteristic of a Charcot joint. So this will come as a spotter, and I hope that you will write it as a Charcot joint. How to differentiate from leprosy? See, Charcot joint, it does not say the diagnosis. It is just a neurological problem. So it can be because of, in a case of polio, or in a case of long-standing infection, or in a case of sacral tumor, or in a case of leprosy. So Charcot joint just tells that there is a neurovascular involvement which is causing the appearance of joint destruction, and these 5 features happen. Okay. So leprosy, from leprosy you cannot differentiate. It can be leprosy or it can be a lumbar or spinal tumor that can lead to a Charcot joint. Both are possible. Now this case 10. Case 10, what do you think it is? I know this is not a focal bone lesion, but still I've kept this for you. Yes. No. Gout, no. Because see, first metatarsophalangeal joint, it is absolutely pristine. 10, diabetic foot, Dr. Abhijit Singh. Absolutely bang on diagnosis. There is soft tissue involvement. There is increased density of soft tissue. There is air in the soft tissue. There is here a ulcer present. Okay, there's a defect in the soft tissue in the first MTP joint area, and there is along with the bones that are showing a little bit of osteopenia. However, the center of attraction in this radiograph is not the bones but the soft tissues. So see the soft tissues and you can imagine what kind of foot the patient must be having with an open ulcer here. So this is a diabetic foot. Osteomyelitis in this patient, in this area, you can say that bone is also getting involved because there is some lytic lesion here just beneath the ulcer. So osteomyelitis, initial osteomyelitis, acute osteomyelitis can be said to be occurring in the area of head of first metatarsus. Madura foot can also have a similar appearance. It is very likely to have a similar appearance in Madura foot as well. Right. 11th, case number 11. Okay, somebody is writing Ewings, and the doctor can. Okay, malorhistosis. No, 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 no. This is not malorhistosis. Malorhistosis, I already have a case. I'll show you. Okay, yes. Dr. Moha has told that it is osteomyelitis. Dr. Suhavi Arora. Yes, so this is chronic osteomyelitis. Okay. So what is happening is why you should not think of Ewings is because Ewings mostly has a lytic permeative kind of bone destruction and it will have onion peel reaction. It will not have sclerosis. What you are seeing in this radiograph is a lot of sclerosis that is causing cortical thickening. There is thickening of the cortex and there is increased density. But in Ewings, you will get decreased density and onion peel reaction. So this kind of undulating type of cortical thickening in large affection of bone. And this is a case of chronic osteomyelitis. Similar case of chronic osteomyelitis in the proximal end of tibia. See, there is increased cortical density, differential kind of densities in the proximal end, not much of soft tissue component or periosteal reaction. So this is a case of chronic osteomyelitis. Why not Brody's abscess? Because Brody's abscess would present as a well-defined epiphyseal lesion with a clear line connecting the Brody's abscess to the epiphysis. Okay. So that is the Brody's abscess ka typical appearance. It will appear as a focal lesion in the epimetaphyseal location and there will be a tunnel that will be connecting the lesion to the joint where the abscess drains. Now coming to case 13. This is a spotter. You have to tell me the answer. 13. You have to write 13 and write, okay? I've told you, you have to write 13 and write, okay? Yeah, myositis ossificans, no, no. Okay, yes, 13 osteochondroma of the left inferior pubic ramus. If you get a spotter or like that, you have to write the correct position of the bone. So left osteochondroma of the left inferior pubic ramus, that would be, I guess, the correct diagnosis. Okay. So, right, that is done. Now, case 14. Now, again, this is not a focal bone lesion, but it is a soft tissue lesion. So, what would you suggest? Cysticercosis. Yeah. However, cysticercosis has a little smaller, yes. The sizes of cysticercosis calcifications are little smaller. This is dracunculiasis, and this is a very rare radiograph which you can get. And this used to happen in early times. It is not common to find such radiographs now. So the right answer is dracunculiasis. Case 15. So this radiograph, if I would have shown you, you would have said that this is normal. But if I show you this one, now is the problem. And you can also see me clicking picture. Right. Yeah, okay, very good. So 15, osteoid osteoma. So this case gives you the importance of always taking two radiographs, which should be at 90 degrees to each other. So eccentric cortical thickening with no periosteal reaction, or with a solid kind of periosteal reaction, and only on CT maybe you'll be able to see the lytic nidus. Right, case 16. Okay, I'll move the chat box a little so that you can see the radiograph well. 16. Already people have given the diagnosis. Very good. So what you can see is there is a large ill-defined lesion, lytic lesion in the involving the large area of the left iliac bone as well as left femur. So two bones are involved, so automatically it becomes a multiple lesion kind of a differential diagnosis. There is the matrix is ground glass matrix. There is no periosteal reaction or cortical destruction or soft tissue component. So this is likely to be a benign lesion. It is involving more than one bone, so it is polyostotic fibrous dysplasia. Okay, this is of course a spotter. I'm sure you will all be able to answer. 17. Very good. So 17 is Freeburg's disease, avian of the head of second metatarsal. Okay, 18. So 18, lateral radiograph, what would you say? If I never gave you the AP1, you would have not seen this lesion. But here it is, very well defined. No, it is not avian. It is not avian. Avian male lunate looks like more sclerosed. The density of lunate is increased in avian. Osteoidostoma, no. Osteoidostoma is a cortical sclerosed kind of structure. Perilunate dislocation, no. Cyst. Finally, somebody saw this. I have been pointing it with my arrow. So this was a ganglion cyst which was causing external erosion of the lunate. And that is why it is important to also examine the patient, because if you examine the patient, you can feel the ganglion cyst, and then you do an ultrasound and you can see that this was a ganglion cyst that was causing an erosion. However, this is a very peculiar appearance of a ganglion cyst causing an eccentric erosion of the lunate bone. Okay, this was a very difficult patient because the patient's daughter was already a doctor. She was in final year MBBS, and the patient came for had a fall from a bike, and she wanted to know whether there was a fracture or not. There was no fracture. The patient was absolutely normal, but then we found this lesion. Right. So the problem was that this was a benign lesion, but it was discovered incidentally, and now we had to give an explanation to a budding doctor that why it was not to be biopsied. So it was an osteochondroma of the humerus. The one lesion was here, and another lesion was on the posterior aspect. So osteochondromas of the humerus, which were benign, completely benign, with no destruction or soft tissue component. However, the patient was radiographed, and that's how it came to light. This was the MR also that was done, but it still showed a very well defined lesion, and there was no malignancy that was involved. Right, case 20 and 21, similar lesions. What do you think the diagnosis is? Okay, 20. Yeah. We have reached 8 o'clock, so I think I'll just take 10 more minutes to finish all my cases. Yes. So, 20, many people have said enchondroma, 21 also. But thing is, you see, uh, this is what I was talking about, ring and arc type of calcification. Okay. However, such large enchondromas in long bones, very difficult to find. So, where your one differential diagnosis would be enchondroma, I don't deny. But medullary infarct is your is the thing that you should remember. Yes, some of these X-rays are not there in, no, not mentioned many places, but this kind of appearance, medullary sclerosis, and large lesions in long bones, think of bone infarcts or medullary infarcts. Okay, case 22. Both are bone infarcts, both were medullary infarcts. Case 20, 21 are both examples of the same thing. One was femur, one was tibia. Two separate patients. That's why I gave. Yeah, 22 maloriostosis. So one answer I've already got. Where is the maloriostosis? You see the first metatarsal, the medial cortex is very well seen. This is what maloriostosis look like. It is called dripping candle wax appearance. Okay. So sclerosis in along the cortex of the bone looking like dripping candle wax appearance. Okay. Type 2 os navicular, yes, of course, that is also present. Case 23. Another example of maloriostosis. So small things like these you should be able to pick up in second proximal phalanx of second digit also maloriostosis is there, and large area of dripping candle wax type of appearance, cortical in location, smooth. And if on AP view you would see, you would also be able to see the maloriostosis. Now, this case number 25, I want you to answer what is the abnormality. Case number 25. 25, right superior pubic ramus GCT, who has Falak Dhaka. Great pickup. And thank you so much for answering so quickly because I know we are tight on the time. But this is the important thing that you have to pick up. The right superior pubic ramus is almost eaten away. Now, thing to see in radiograph is that the margins of the bone is completely destroyed. So even if I say that there is narrow zone of transition, there is this abnormal bone and there is this normal bone. However, the bone has been eaten away. So this would not be a narrow zone of transition. Okay. This is more likely to be a malignant lesion. So in this patient, it was a plasmacytoma that was causing pain and soft tissue swelling on the right side of the pubic bone. And it was a very aggressive and malignant lesion. So this is a very important finding to be picked up. Sometimes we see what is there, but what is not there also has to be picked up. Right. Case number 26. I'll remove the chat box on the side. Now, this is a spotter. You have to give the diagnosis. 26. Yes, so somebody has written HME osteochondromas. Most of you have picked up. But anything else? See, it is there also, here also. One is here also. So, multiple osteochondromas are present. Okay, of the nail. Yeah, nail patella syndrome is one thing that you must think of. However, the shape of the iliac bones is relatively preserved. So HME is, I think, one of the possibilities. Okay, case 27. What you see here, 27, one or two answers, just give it to me so that I'll start the explanation. Thalassemia. Okay, yes, you are on the right track. What is you can see is the bones are a little expanded. They are the cortical thickening is there. Trabecular exaggeration is there. Okay, can you see the trabecula appears so prominent, and the on the lateral radiograph you can see that there is squaring of the vertebral body. So this happens when there is less production of the blood cells by the marrow, and the actually the red marrow that is there in the spine and the spleen, they go into hyperfunctioning to cover up for the normal marrow that is not working. So what happens is there is intrabecular exaggeration and there is squaring of the vertebra. Cases like hemolytic anemia, thalassemia, myelofibrosis, hemolytic disorders can all show this kind of appearance. So this is a very good pickup. Posting of trabecula by Dr. Palak, and all of you have answered. Good pickup. Okay, this lesion. I have shown many cases like this. So this thing I think you must pick up. Okay, right. So metadiaphyseal junction, tibia, uh, bone. So very typical site for non-ossifying fibroma. Very good. 29. Okay, osteoid very good. But what is happening in the another radiograph, the lateral radiograph? Why is this tract present? RFA. Okay, very good. So you have picked up this. This is a case of osteoid case number 29, and the tract is showing the RFA being done, and after that, the nidus is no longer visible. Case number 30. Any abnormality? Yes, somebody was asking me why was it not malorostiosis. So this is malorostiosis. So if it is typically at metadiaphyseal junction, then it is more a possibility of non-ossifying fibroma, NOF, because that is a typical location. And this kind of appearance, like a dripping candle wax type of appearance, is typical of malorostiosis. Case number 31. Easy to identify. See, this one is this patient's birth date is 9/11/2008. The radiograph is 2023. Okay, osteochondroma. No, no, don't say osteosarcoma. After so much of explanation, you have to say osteochondroma. Yeah, okay, osteochondroma. It looks like a benign lesion which is growing away from the joint. So, osteochondroma. Right. 32. Again, a very typical benign lesion. Osteochondroma. Ganesh says osteochondroma, very good. I would request if it is possible to write case number because now we are getting going a little faster. Okay, case number 33. 33. What do you see? 33, osteoblastoma. Okay. Why osteoblastoma? If it is if the size of the lesion is less than 1.5 centimeters, still consider osteoid osteoma. If it is larger lesion, osteoblastoma is a possibility. Okay. So it's in the in the vertebral body, in the posterior elements, and what you can see on CT is the nidus also present. So osteoblastoma and osteoid osteoma both are possibilities. If it is a smaller lesion, osteoid osteoma. If it is a larger lesion, osteoblastoma. 34. This should be easy to pick up. This enough and more of this we have discussed. 34, osteosarcoma. Great. Proximal tibia, and it is eating away almost the proximal fibula, and the lesion is causing Codman's type of periosteal reaction. There is cortical destruction, interrupted type of periosteal reaction, large soft tissue component, and infiltrative lesion with moth-eaten or permeative appearance and wide zone of transition. Okay. Osteomyelitis can be a DD. For a lot of malignant lesions, you can have a DD of osteomyelitis. So keep it lower on your differentials. See, whenever you are reporting X-rays, do not close your channel of reporting. Always try and say, keep your options open and say that it is likely my differentials are 1, 2, 3. However, in such cases, I would like to entertain only differential number 1 and 2. That is how you should answer. Case number 35, people have already answered. So this is not a focal bone lesion, but I kept it for you to recognize that this is a rickets case. Metaphyseal flaring, metaphyseal widening, fraying and of the metaphysis. There is roundening of the epiphysis and small epiphysis. So this is case of rickets. Now case number 36. So what is the diagnosis? 36. Okay, very great. Dr. Harsh has already answered, and that is the correct answer. This kind of X-rays are very common to be kept in spotters. The important thing is that whatever is shown is normal, but the patient has had an amputation. So it's important to pick this up and write it in the spotter. Sometimes a baby is shown. Infant's radiograph or kiddogram will be shown with arm missing. So that can happen in amniotic band syndrome, and that would be needed to be picked up by you. Okay, so those are the kind of spotters you have to be careful about. Now, case number 37. I only have 38 cases, so this is the second last case. This is not a focal bone lesion, but the diagnosis has to be mentioned by you. Yeah. So Sprengel's deformity, there are multiple vertebral anomalies. One, the right scapula is deformed. And so this is one example of Klippel-Feil or Sprengel's abnormality. There are multiple vertebral abnormalities. There is dorsal scoliosis towards the right side. All these things you will have to write and explain if there is this comes in your rapids. Okay. Last case of the evening. What is the lesion? Where is the lesion? Okay, 38 acromegaly, avian talus. No, both are not correct. Normal, no. Fibula, no. Coalition, no. Retrocalcineal calcaneal bursitis, no. OCD, no. Severe disease, no. Talus, yeah, okay. Somebody has answered. Stanzen, Dr. Stanzen, posterior talus cyst. So here is your lesion. There is a small lytic lesion which is well defined in the posterior aspect of the talus. The zone of transition is very narrow. There is no destruction or periosteal reaction and no soft tissue component. This is a simple cyst in the talus. And that had to be mentioned and explained to the patient that there is a benign lesion which does not need any further intervention by the patient or the doctor. So thank you so much. I have finished today taking my class. I have exceeded my time a little. However, I hope that all of you enjoyed the class as much as I did in taking it. And it was, it could be an enchondroma, last one, talus cyst. So keep that. However, there was no ring and arc type of calcification. So I would not keep enchondroma higher in the list. Okay. And thank you so much.